Good morning, everyone. We're going to talk about chronic otitis media and cholesteatoma and the various forms of mastoidectomy that are used for chronic otitis media this morning. So the first question is, of course, why do we have a middle ear in the first place? The reason is, if we look at, for instance, if we're fishing, we're all told by our grandparents to be very quiet so that we don't scare the fish. But in fact, the impedance mismatch between air and water is so great that if you try to yell at a fish, 99.9% of the energy is reflected off the interface with the water. And so the fish hears nothing. And the inner ear has the same problem. The organ of Corti lives in water, and without a middle ear mechanism, again, 99% of the energy is going to be reflected away from the water environment, and therefore the middle ear is an impedance matcher that takes the vibrations in air over a large area, and by the principle of hydraulics, turns that into a vibration in a very small area. So the middle ear compensates about 25 decibels at 1,000 hertz. And most of that is because of the area ratio between the area of the tympanic membrane and the area of the foot plate. A little bit is contributed by the lever action of the malleus, which is longer than the lever of the incus, and therefore you recoup another 2 or 3 decibels by the differential lengths of the lever. In order to maintain this mechanism, we need an air-containing middle ear space. Air in a closed space anywhere in the body will slowly be reabsorbed, and therefore the air is continuously replenished through the eustachian tube every time we yawn, swallow, move the jaw, etc. So the middle ear is a transformer. It is changing the magnitude of energy, but it is the same kind of energy. It's still vibratory. Just like an electrical transformer that can boost the voltage up or down. So there are many reasons for conductive hearing loss, and I'm sure this is familiar to everyone. Most common, of course, fluid within the middle ear space, perforation of the tympanic membrane, damage of the ossicles, otosclerosis, and of course, cholesteatoma. And you see this beautiful eardrum here. Rarely do we see a drum that is this translucent, but this is, of course, a right ear as projected, with the malleus oriented from anterior superior to posterior inferior. You can see through the drum to see the incus, the stapes, even the stapedius tendon, and the round window niche down here. So the root cause of otitis media, of course, is dysfunction of the eustachian tube, not allowing or pumping air into the middle ear space, and leading to otitis media. Otitis media is very common in children, affecting half of children by the age of 3. And there are a number of risk factors, including exposure to passive smoking, exposure to daycare. The more bugs you're exposed to, the more likely you are to get sick. Upper respiratory infections and genetic susceptibility. If your parents had lots of otitis media, then your risk is increased. And this is counterbalanced by breastfeeding, which transfers enough antibodies to have a protective effect, at least in the early months. Host characteristics are also important in otitis media. The function of the eustachian tube, whether or not the nasopharynx is a reservoir for bacteria, of course, the organism itself and its drug resistance, and allergy, no doubt, plays a role as well. Differentiation between acute otitis media and otitis media with effusion, which is often a long-term sequelae of acute otitis media. So acute otitis media is an abscessed ear, it's pus under pressure. The distended tympanic membrane is painful. And whereas otitis media with effusion is a retracted tympanic membrane, and you can see how this malleus is pulled posterior superior, and the obvious bubbles and yellow fluid behind the tympanic membrane. Both cause a hearing loss because of an inhibition of movement of the tympanic membrane. So medical management is generally with antibiotics, and if that fails, then myringotomy and tube is a substitution of the eustachian tube. It allows egress of the fluid, but more importantly, allows aeration of the drum, of the middle ear space, rather, to improve the hearing loss and vibration of the tympanic membrane. So here is an example of a tympanic membrane perforation. It's a rather angry one. It's wet. The middle ear mucosa, you can see through the middle ear, through the perforation, is inflamed, as are the edges of the tympanic membrane with some granulation tissue around the margins. When we talk about repair of the eardrum, the risk of a simple perforation is quite small. But many people get recurrent otitis media when they have a tympanic membrane perforation, and very frequently this is from repeated external contamination, either shower, shampoo, or swimming pool or lake water getting into the middle ear through the perforation, washing bacteria into the middle ear. So a good indication for tympanoplasty is the desire of the patient to resume water-related activities. Also, particularly with a marginal perforation, and I guess I should go back and define those, this would be considered a central perforation because you can see a rim of tympanic membrane all the way around it. If the perforation involves the margin of the tympanic membrane and the annulus, then the patient is at much higher risk for developing cholesteatoma. The reason for that is that the skin of the tympanic membrane is very special. And it's the only skin in the body that moves laterally as it grows. So if we look at, if we put on a normal tympanic membrane, if we put a dot of India ink on the center of the eardrum and serially watch over the next weeks, we will see that dot migrate from the center out to the edge of the drum and then out the ear canal. So the skin of the drum moves and the ear canal moves laterally with time. And this is a cleaning mechanism for the drum and the canal. But if you have a marginal perforation, then that lateral motion can get confused and the skin can grow into the middle ear, causing a secondary acquired cholesteatoma. So a marginal perforation is a good indication for tympanoplasty. And of course, we would like to improve hearing as well. And the expected change or the expected loss from a perforation is around 30 decibels for a perforation with a otherwise intact middle ear. If there's a perforation combined with ossicular damage, we're thinking more of a 45 decibel loss. And of course, the worst loss occurs with an ossicular discontinuity with an intact drum, because you have the tympanic membrane acting as a reflector for sound with no connection to the inner ear. The graft, when we do a tympanoplasty, serves only as a scaffold for epithelial growth. And I don't think the particular material is terribly important. Temporalis fascia has been the mainstay for years and years, since a guy in private practice named Lloyd Storrs in Lubbock, Texas, first described temporalis fascia tympanoplasty in the 70s. Before that, we tried split thickness skin grafts, which always took and always broke down with time. So split thickness skin graft is not an effective graft material for a drum. I like tragal perichondrium because it maintains its structure a little bit better than temporalis fascia if you don't get it in the first pass. And then there are homograft materials, otologic repair grafts, and so forth that I think some of our pediatric colleagues like, because they don't require a graft site for small perforations left over from tubes. But the material, I don't think, is nearly as important as the placement of the material. And you need good apposition of the graft to either the underside or the outer side of the drum. And it's very important that you thoroughly rim the perforation so that there's no residual bridge of the outer skin and the inner mucosa remaining. Otherwise, there is no reason for the the skin to grow across the tympanic membrane defect. Ossicular chain reconstruction involves replacement of some or all of the ossicular chain with either natural or prosthetic materials. You can use the incus for an interposition. There are all kinds of alloplastic materials, hydroxyapatite, and most commonly, more recently, titanium implants. But they all come down to two general categories, either partial replacement or total replacement prostheses. And the difference is whether or not the arch of the stapes is maintained or not. So if the arch of the stapes is maintained, you only have to go from the stapes to the undersurface of the drum. In this instance, buffered by some cartilage between the drum and the prosthesis. And with the total, you're going from a foot plate all the way to the drum. This geometry is more difficult to maintain than the partial, simply because the prosthesis can sit down on the arch of the stapes and be more stable, whereas you're dealing with two floppy ends, this end sliding around as well as this end sliding around on the foot plate. And we now have some little ball and socket joint shoes that we can put on the foot plate to try to maintain a centering of the prosthesis on the center of the foot plate. But suffice it to say, with a broad brush, our odds of getting serviceable hearing with partial ossicular replacement prosthesis is in the range of 80%, whereas with a total ossicular replacement prosthesis, we're talking more 50-50 serviceable hearing results. This is a very difficult situation, and we see these all the time. You see a tympanic membrane which is totally collapsed and atelectatic. It's shrink wrapped down over the incus, around the stapes, around the malleus, even down into the round window niche. These are difficult cases to manage. Curiously, they often have pretty reasonable hearing. You can see here erosion of the long process of the incus, just barely touching the stapes, but still in continuity. Here, the incus seems to be totally absent. Myringotomy tubes are singularly ineffective in this situation because this drum is stuck to the promontory. So even if you can get a tube in, the drum is not going to pop out the way it does with a more acute effusion. The difficulty, although people have talked about going in and lifting up this thin drum and attempting to do a cartilage tympanoplasty. The risk is that you tear some of this exceedingly thin membrane, either back here in the sinus tympani or around the round window, or where it's attached to the stapes. And if you do that and then put a new graft in, you've caused a cholesteatoma because you've left squamous epithelium buried in the middle ear. So my management in these cases is to image them, to see if there's any erosion in the antrum that is suggestive of cholesteatoma or expansion. And if not, I observe these ears. I see them frequently. I re-image if I get concerned, but I try not to operate on these severe atelectatic tympanic membranes. We talked a little bit about cholesteatoma. Of course, there are congenital cholesteatomas that are generally seen in the pediatric group. So for our adult patients, there are two basic categories: primary and secondary acquired. So a primary acquired cholesteatoma is an attic retraction pocket. Here is the short process of the malleus. So you can see this is entirely in the pars flaccida of the drum. And you get a little retraction pocket, and then that can't self-clean, and the keratin starts to build up, and you get an expanding keratocyst. Very important that when you do your physical examination, you see this pars flaccida portion of the drum. If you just jam an otoscope in an ear, you're going to see the pars tensa down here, which is totally normal in most of these cases. But you have to get the head tilted away so that you can see the short process and see the pars flaccida above it to make sure that there's not an attic retraction pocket pathology. Secondary acquired, as we said, is a traumatic perforation or marginal perforation that has allowed ingrowth of cholesteatoma from the drum or the ear canal into the middle ear, forming a cholesteatoma. So it's no more than an epidermal inclusion cyst. Cholesteatoma is an old word coined because of misinterpretation of cholesterol cysts in histology. So we're sort of stuck with the name, although in terms of the etiology, it has nothing to do with cholesterol. There are lots of theories of pathogenesis. Of course, we do have congenital rest left in the middle ear. And we talked about retraction pocket and ingrowth through perforations. And there's some thought that you may have squamous metaplasia of the middle ear differentiating into mature squamous epithelium. That's more speculative, although it has been proposed. Symptoms, they can be totally asymptomatic, particularly if they have not caused any damage to the ossicular chain. They can cause a progressive conductive hearing loss, or they can be infected with foul purulent drainage and polyps in the external auditory canal. Complications of cholesteatoma include sensorineural hearing loss if it grows, if it erodes the promontory or grows in through the round window. But more commonly, you can see facial paralysis from expanding keratocyst within the mastoid. Vestibular symptoms with lateral semicircular canal fistula, and ultimately meningitis or brain abscess in advanced cases. Imaging is important in cholesteatoma. But I caution you to order imaging when you have a question that imaging can answer. So it is a useful tool for surgical planning, but don't use imaging as a screening tool. You should know if there is a cholesteatoma or not. So it drives me nuts when I see a CT requisition rule out cholesteatoma because the radiologist can tell you if the antrum is opacified. They can't tell you if there is a cholesteatoma or not. You should know that. Imaging is also useful in follow-up after intact canal wall tympanomastoidectomy. And with MRI scan with diffusion images, we can actually differentiate chronic inflammatory tissue in a mastoid cavity versus cholesteatoma. And I think we saw this image yesterday, lateral semicircular canal here, grossly eroded by an expanding cholesteatoma that has taken out the entire mastoid cavity on that side. Here is a huge cholesteatoma. You can see normal mastoid on this side, and the whole skull base is blown away by an expanding lytic mass, which was cholesteatoma in this instance. And here's a more classic CT scan, axial on the left, showing this irregular scalloped appearance. The borders are smooth. They're not moth-eaten like you'd see with a malignancy or a glomus tumor. And in the coronal image on the right, you can see a large dehiscence of the tegmen, complete absence of the external auditory canal, and near erosion of the lateral semicircular canal there, and no remnant of ossicle on either side. And I guess the same picture. So I'm going to take a quick pause here before we start talking about the surgical approach to see if there are any questions or comments. Anyone out there awake?
I have a question.
All right.
This is Melissa. When a patient has really bad tympanosclerosis and it's difficult to see beyond the eardrum, are there any clues for cholesteatoma to do for a clinical diagnosis?
So in that situation, where you, once again, where you really want to look is the pars plana, because that tells you that this patient has had a lot of ear infections in the past. They've got tympanosclerotic deposits in the drum. If there, you know that this started a long time ago. That this is not the result of a recent infection. So in that case, the odds are that if there's a cholesteatoma, you're going to see it so long as you look in the right place. And you want to look at that attic area. And if that's clean, I would not be terribly worried about cholesteatoma.
Thank you.
I have another quick question. What's your experience or belief with eustachian tube balloons in these atelectatic ears? And do you think there's any role for any of that?
So I think this is a novel idea. I don't have any personal experience with balloon dilation. I've not gotten on that bandwagon as yet. I think it has a role, particularly in more acute or recent onset eustachian tube issues. It's hard for me to believe that 2 minutes worth of dilation is going to reverse 40 years of eustachian tube dysfunction. But I'd love to be wrong. Okay, so let's go ahead now and talk about our surgical approaches. And of course, a mastoidectomy means removal of the air spaces of the mastoid, and generally there's pathology of the middle ear or drum, and we combine it with some kind of tympanoplasty procedure. And here is the menu that we will go through. We'll talk about adichotomy, then intact canal wall down, radical mastoid, and ultimately subtotal petrosectomy. So we'll start with adichotomy, and that is the transcanal marsupialization of cholesteatoma with either curettes or drills. And it's appropriate for very small, limited cholesteatomas in Prusak space. Prusak space is the space between the body of the incus and the head of the malleus on the medial side, and the scutum on the lateral side. So it's this little space right here. If cholesteatoma has gone medial to the ossicles, you're unlikely to get it out with a simple adichotomy. And basically what we're doing is we're going through the canal, usually with a postauricular approach, but occasionally with, if it's really small, through an endoral approach. But we're basically taking this piece of bone, this corner of bone, the scutum, away so that we can marsupialize that keratocyst, and hopefully reducing the pressure within it and decreasing its likelihood to continue to grow superiorly. So here is an attic defect here with keratin in it. So this is a right ear in the surgical position. You see the malleus here, and here is the keratin within the cyst. So let's just, so I've done a postauricular incision, and this is a 2 millimeter drill or 3 millimeter diamond burr, and we'll just start drilling away that scutum. And you need to keep drilling until you get to the limits of the keratocyst. And that's always farther than you think it's going to be based on the imaging. So we'll keep going here a little bit. And ultimately, we want to get to all the edges and then lift out the debris within the keratocyst. And once we do that, we should have a good view of the heads of the ossicles. So now we've finished. We have resected the damaged atelectatic part of that drum. You can see a head of malleus and body of incus here. Here's the short process of the malleus. Pars tensa is perfectly fine here. chordotympany nerve still preserved, and here's the long process of the incus coming down here. So now we need to graft this, and I generally use a graft from the tragus. So here is the exposure of the tragus. Being careful to preserve the perichondrium on both the front side and the back side and the connection around the edge so that we can reflect the perichondrium off one side so that it's longer than our piece of cartilage, and it'll help stabilize the graft in the canal. And so here now, once again, here's the pars tensa. Here's the cartilage graft in place, covering the heads of the ossicles. And here's the extension of the perichondrium coming up the ear canal. So that's an adichotomy. And as I said, that's for very limited disease, but very useful in the right indication. So our next step now is intact canal wall or canal wall up mastoidectomy. And we're going to do a mastoidectomy, but we're going to preserve the partition wall between the external auditory canal, middle ear, and the mastoid cavity. We only need the surgery only needs to be extensive enough to remove the disease. So if the disease is limited to the attic here, we don't need to get down into the tip of the mastoid or expose the sigmoid sinus. If it's larger disease, of course, we need to expose more. You can see the incus and the head of the malleus and the semicircular canals again. And we can elevate the skin of the external auditory canal and, of course, work through the middle ear at the same time. The advantage of the canal wall up is that we leave the normal external auditory canal. Healing is faster. It's easier to reconstruct the ossicular chain because our middle ear space is normal. You'll see when we do the canal wall down, we considerably shrink the middle ear space. The risk of intact canal wall is that of hidden recurrence back here in the mastoid. These patients need surveillance. In the old days, we did a lot of second look surgeries to look again. Now we can generally avoid that with imaging and only reoperate when there's a serious question of recurrence. Canal wall down mastoidectomy involves a total removal of the air cells, removal of the external auditory canal. We want to take that canal down to the level of the facial nerve. And now it's important that we do remove all visible air cells, because if we leave air cells lined with mucosa, those are going to risk hypertrophy in the healing period, leaving you with a wet, mucosalized cavity that continues to drain despite the surgery. So you need to do a much more thorough exoneration of the air cells than you do in an intact canal wall. Fortunately, these are usually chronic ears with smaller mastoids, so that's easier to do. This cavity we've essentially marsupialized the mastoid into the external auditory canal. These cavities accumulate cerumen and skin, and therefore it's important to do a mastoidectomy to facilitate cleaning of the cavity for a lifetime. The drum is going to drop down onto this facial ridge, which is much more medial than the normal annulus of the external auditory canal. So although you can do ossicular reconstruction with the canal wall down, it's somewhat more difficult because of the constricted middle ear space. The advantage, of course, is that any recurrent occurrence of the cholesteatoma is automatically exteriorized into this cavity where it can be seen readily through the mastoidectomy. And so in patients whom you think surveillance and long-term care is going to be more limited, there are certainly advantages to the canal wall down. So just a comparison between the two. Canal wall down is dictated by extensive cholesteatoma, particularly in the anterior epitympanum that you can't get to with the canal wall up, or an ear that the tegment is right down on the external auditory canal and there is no space to do an intact canal wall procedure, and your preoperative coronal imaging will help with this decision making. Sclerotic mastoids with limited cavity are ideal for canal wall down. And we talked about the recurrence and the lifelong cavity care with canal wall down mastoidectomy. Now, a radical mastoidectomy is little different from a canal wall down. The difference is there is no attempt at preservation of any air-containing middle ear space. And so we're going to obliterate the eustachian tube, and we're going to put our graft from the anterior canal wall right down onto the promontory, and then drape over the mastoid cavity. So there's no opportunity now for a hearing reconstruction after a radical, and it's usually reserved, at least in my practice, for those ears that have had a canal wall down that continue to drain, and the site of the drainage is from the middle ear. Sometimes a canal wall down cavity will drain because of retained mucosal elements in the sinudural angle, and that can be managed by local revision surgery. But if there's recurrent infection in the middle ear, then radical mastoidectomy may be your alternative. And lastly is a subtotal petrosectomy, which is, again, the same bony work. However, we're going to close the external auditory canal and obliterate the cavity, generally with a temporalis mastoid periosteal flap. I don't use fat in these cases because they're usually infected, and the cholesteatoma, the fat gets infected and has prolonged healing afterwards. So it's useful for big cholesteatomas, encephalocele, CSF leaks. Obviously, since we've closed the ear canal, there's no opportunity for hearing reconstruction. And the disadvantage that any recurrent disease is totally hidden. And the only way that we can follow these patients is with MRI imaging. So let me just show a couple of clinical cases. Here's an elderly lady with a draining ear. She's never had surgery. You can see the mastoid is totally gone. Somewhat unusual in that her lateral semicircular canal is intact, but the posterior semicircular canal has a fistula. And here, so this is a left ear in surgical position. You can see just raising the periosteum, there's cholesteatoma visible here, and with limited exposure here, you can see this whole large cavity filled with cholesteatoma. And here's just the initial exploration and teasing out of the cholesteatoma. Sometimes you need to debulk this just to see where you are, but it's really critically important that once you get down to the matrix, you want to have good visualization and tease the matrix systematically from one corner to another so that you don't leave bits and flakes of matrix behind. This is the final picture. You can see the dura pulsing here from the tegment defect and the posterior fossa defect. We had a little CSF in the vicinity of the internal auditory canal. So now we're ready for obliteration with flap. Let's see here, I guess that's the end of that. So that's a brief run through of cholesteatoma and progression of mastoid surgery. So again, I'll open things for questions.
Dr. Mattox, I have two questions. First question is, in a massive cholesteatoma case like that where you have to overclose the ear, have you ever had a situation where you're concerned for recurrence? And then if so, what do you do then? And then second question is, can you just touch on what a Bondi mastoidectomy is?
Sure. So a Bondi is a canal wall down, except that you leave the ossicular chain intact. So if you have a cholesteatoma that is really limited to the attic ear, involves the heads of the ossicles, but you can peel it off and it's not invading the middle ear, then you can peel that cholesteatoma off the ossicles, leave the ossicular chain and the pars tensa intact, and do a more limited canal wall. Well, you have to, the extent of the canal wall down bony work is dictated by the pneumatization. But that's what a Bondi is. You're not taking out the incus or the head of the malleus, you're leaving it intact. And, obviously you're hoping to have better preservation of hearing in that situation. So in the obliterated cavity, Follow-up is really important because, as we said, there's nothing to see. You've closed the external auditory canal, and so you have to close with imaging or follow with imaging. And fortunately, our diffusion-weighted MRI scan can give you a pretty good idea whether you're looking just at fat and muscle in the cavity versus cholesteatoma. And if there's a legitimate suggestion of cholesteatoma, you're going to have to go back.
Yeah, so I have a question. Do you find any role for doing like inside out mastoidectomies? Is that the same as a Bondi procedure, or is that different? And when would you do that?
So an inside out is pretty much what we discussed with an adicotomy, except that you keep going. So I try to keep the cavities as small as I can. If you have a really sclerotic mastoid and an antral cholesteatoma, you can start with the typical post-auricular incision, but instead of starting at the mastoid cortex and drilling in, you can start at the scutum, as we illustrated with the adicotomy, and keep going posterior until you reach the limits of the cholesteatoma. And that will keep your cavity smaller than if you start to do a wide exteriorization. So it's not the same as a Bondi. Bondi is whether you've gone into and rearranged anything in the middle ear or not. But it's certainly an approach that I use in a small sclerotic mastoid with a fairly limited area of cholesteatoma.
One other question. Do you find any use for doing, or any thoughts on doing mastoidectomies for people with really atelectatic ears, or like to try to improve the middle ear aeration at all? Is that something that is considered at all, or that you would consider at all?
You know, we used to think that the mastoid was an air buffer. And so if you could drill out a big cavity, you'd have a bigger air buffer for the middle ear. But really, the root cause is the eustachian tube. And I have been pretty disappointed in what I could accomplish for people by just drilling out the mastoid, because you're not addressing the root of the problem. All right. Well, thank you everyone for your attention, and I'll see you this time tomorrow.
Thank you.
Thank you, Dr. Mattox.
Bye-bye.